What we wanted to do was assess how the analytical limited detection of the ctDNA assays impacts the prognostic performance in first-line diffuse large B-cell lymphoma therapy at different time points. We also assessed the incorporation of ctDNA MRD at end of treatment into a novel surrogate endpoint to see whether this may be able to shorten trial time. We use a pooled cohort of 5 different cohorts, all with prospectively collected samples that were assessed via phase-seq. We then simulated limits of detection by reclassifying samples by the variant allele fraction. So for those with variant allele fractions lower than a given limit of detection, we reclassified them as MRD negative. We did this for limits of detection 10 to the negative 2, 10 to the negative 3, 10 to the negative 4, 10 to the negative 5, and 10 to the negative 6. So we used those simulated limits of detection to assess the clinical sensitivity and the predictive ability for progression-free survival at each of the time points before, during, and after treatment for diffuse large B-cell lymphoma. Early on in treatment, the depth of limited detection does not make a major difference in either clinical sensitivity or predictive ability for progression-free survival. However, as you get to later in treatment, particularly at cycle 3 and beyond, the lower limits of detection, down to 10 to the negative 6, have significantly improved clinical sensitivity and predictive ability for progression-free survival. We think that because the circulating tumor DNA variant allele fractions are much lower at those time points, that we really do need that extra sensitivity, analytical sensitivity with those lower limits of detection in order to accurately detect diffuse large B-cell lymphoma at those time points. We then assessed what a modified progression-free survival would look like in our cohort with a limited detection of 10 to, using the phase-seq assay with a limited detection 10 to the negative 6. We looked at overall survival, progression-free survival, and modified progression-free survival, and how long it would take to get to a target event rate, for example, of 25%. For overall survival, we don't reach that target event rate within 2 years. However, progression-free survival, the standard progression-free survival, we reach that target endpoint within 18 months. But with a modified progression-free survival incorporating the phase-seq assay at end of treatment as a positive event, you're able to reach that time to target event rate of 25% within just 6 months, potentially shortening the time to trial readout by a year. We also showed that progression-free survival and modified progression-free survival events were highly concordant, suggesting that this can serve as an accurate surrogate endpoint. The use of modified progression-free survival has the potential to significantly reduce trial time and improve clinical development in first-line diffuse large B-cell lymphoma and warrants further study as a surrogate endpoint.